Hello and welcome to our session today. Today we're looking at antipsychotic medication. They are also referred to as neuroleptic agents. Okay, so these neuroleptic drugs they work by primarily managing the symptoms of psychosis, which could be positive symptoms like hallucination, delusions, disorganized speech, disorganized thinking for that case, or even negative symptoms. Okay, so these antipsychotics drugs they are commonly prescribed for conditions like schizophrenia. We could have bipolar disorder or severe depressions. Guys, a link will be popping up for all these conditions. You can review them at free time. So in attempt to treat these conditions, antipsychotic medication work by blocking the dopamine receptors in the brain, specifically the D2 receptors. So in the process, they will help alleviate the symptoms associated with this condition. So we must know the cause of this condition for us to try and exploit it at pharmacology level. And to answer that question, the dopamine hypothesis is there to help us, okay? So the original dopamine hypothesis states that brain of schizophrenic patient will produce more dopamine than the normal person. So through further research, it's now thought that schizophrenic now have abnormally high level of D2 receptors in the brain. So in order to treat this condition, we have to block the D2 receptors in the brain. Remember, dopamine is very key in mediating the mood, the pleasure, and the motor activities. So if you are going to block this dopamine, then we are going to see some side effects associated with all these traits in the human body. In doing so, we have four major dopaminergic pathways in the brain, and the first one that we know is the Mesolimbic pathway. These Mesolimbic pathways will originate from the ventrotegmal area, and then it will project to other limbic structures. All right, so it will project to other limbic structures, such as the nucleus accumbens, amygdala, right, and then the hippocampus, right, and then the hippocampus for that case. So this pathway is involved in the reward and motivation process. So naturally it is hyperactive. Okay, we have at least production of dopamine, okay, is actively engaged here. So in that case, we normally have, if we have a dysfunction in this pathway, okay, dysfunction in this pathway is gonna lead to positive symptoms, okay, that is characterized by hyperactive dopaminergic neurons in that case, okay, and this could be present or key indicator for schizophrenia, where patients are going to present with positive symptoms like hallucination, delusions, disorganized thinking, okay, and hallucinations, and even suspiciousness, being paranoid, okay. So you find that when you look at now schizophrenic patient, you find this pathway will be hyperactive, right? So we can simply treat these positive symptoms by blocking the D2 receptors, and in this case at least the patient will be relieved of some of these symptoms. The second pathway is the mesocortical pathway, and this mesocortical pathway is so different, and we have to really understand it. It's slightly different from the mesolimbic, okay. In the case for the mesolimbic, you find it is hyperactive, but in this case, this pathway is already underactive, right? It's already underactive, okay. So we have to see how we are going to manage this condition. Of course, both mesocortical and mesolimbic they all originate from the ventrotegmal area, and this pathway will now be projecting to the prefrontal cortex as for the case of mesocortical, okay, mesocortical, now the cortex for that case. And this mesocortical is involved in executive function like the cognitive control, emotional control, and you find that dysfunction in this area will normally lead to negative symptoms of schizophrenia. Okay, so a schizophrenic patient will have negative symptoms, will be having underactive mesocortical pathway. So what happens if you block the D2 receptors in this region? Remember, it's underactive and you're blocking it again, you're blocking the D2 receptors. What is going to happen? It's going to worsen. It's going to worsen the symptoms, the negative symptoms of schizophrenia. And I hope you can understand how different it is from the Mesolimbic. For Mesolimbic, it's hyperactive. You can simply block the D2 receptors and the patient will be relieved of those symptoms. But in this case, you can see it's already hyper underactive. Okay, so if you further block it, it worsens these signs and symptoms for that case. Okay. The third pathway is the nigrostriatal pathway, and this nigrostriatal pathway will arise from the substantia nigra. So this pathway innervates the stratum, right? Specifically the caudate nucleus and the putamen for that case, okay? And the nigrostriatal, you can be able to see it in that region for that case, and it does play a crucial role in motor control and coordination. Okay, so if you need purposeful movement, which is pathway is responsible, the nigrostriatal pathway. But I can tell you we have dopamine, the D2 receptors in this pathway, guys. So what happens when you block these receptors in this pathway? We are going to distort the movement, okay? We are going to distort the motor control. So in such a case, we are now going to have a disorganized movement, okay? Uh, so that's why in this region, we are saying that this is the region that is characterized by the extrapyramidal side effect, okay? Then so when you block this region, we are going to result into extrapyramidal side effect, okay? That becomes the most side effects of these antipsychotic drugs because of interfering of the nigrostriatal pathway. So in doing so, we normally again induce another pathology, okay? That's why one of the extrapyramidal side effect, apart from acute dystonia, akathisia, tardive dyskinesia, we have Parkinsonism, okay? So that's why we commonly say when you treat schizophrenia, you induce Parkinsonism, okay? You induce Parkinsonism, and that should at least help us to see that, okay? Anyway, the key thing is that blocking of D2 receptors in the nigrostriatal pathway will lead to extrapyramidal side effects. The last pathway, dopaminergic pathway, is the tuberoinfundibular pathway. This one extends from the hypothalamus to the pituitary gland, okay? The tuberoinfundibular pathway. This pathway's major role is to regulate prolactin secretion. So when you have dopamine there, prolactin secretion is regulated. But when you block it, as in the case of antipsychotics, what happens? You're going to have excessive prolactin, okay? That's why we say antipsychotic medication can lead to hyperprolactemia, excessive prolactin, okay, in that case, because we have blocked dopamine receptors in this pathway. As a result, patient is going to present with menstrual irregularities, galactorrhea, and sexual dysfunction. Guys, we have a unique drug from the atypical ones, and this is aripiprazole, and this is a partial D2 receptor agonist and is thought to have a lower risk of hyperprolactemia than these other drugs, okay? So guys, in short, we have four major pathways that are involved in dopamine. Of course, we have even closer to 6, but 4 are more important to us. This is the mesocortical, the one that is associated with the negative symptoms, followed by mesolimbic, the positive symptoms, Nigrostriatal, the one that you've said, if you block, will result into having extrapyramidal side effect. And Tuberoinfundibular, where if you block dopamine, then you are going to have excess prolactin. So the patient is going to suffer from hyperprolactemia symptoms like menstrual irregularities and galactorrhea, or sexual dysfunction like for the men in that case. Okay, remember dopamine, these drugs, we block several dopamine receptors, and naturally we have at least a number of them. We have the D1, the D2, D3, D4, D5. Okay, so studies have shown that in patients with schizophrenia, we have an exaggeration of D1 and D2. Okay, but D2 is the one that we'll really concentrate on, because that is where most of these neuroleptic agents are going to concentrate. Okay, they are going to be blocking the D2 receptors, and that's why we are going to pay more focus on the D2 receptors. Okay, so naturally, when you try to visualize a patient who has schizophrenia, in most cases, they normally have excessive dopamine transmission, okay? Especially the Mesolimbic region, okay? And the Nigrostriatal region, and the Tuberoinfundibular region. Okay, the only place that may be not be affected by excessive dopamine is the Mesocortical region. Okay, the one that mediates negative symptoms for that case. Okay, so these drugs, apart from the D2 receptors, which is normally blocked by the atypical and serotonin receptors, they also block the noradrenergic, the cholinergic, and histaminergic. So some of the side effects associated with these drugs will be related to these receptors that we shall be blocking. Okay, for that matter. All right. So in general, we have two types of these drugs. We have the typical antipsychotics and atypical. Okay, so the typical, these are old antipsychotics. Okay, the old ones. Okay, they were the first drugs to be developed, guys, and they primarily block the dopamine receptors in the brain, specifically the D2 receptors. These drugs include haloperidol, chlorpromazine, and flufenazine. So these drugs tend to be very effective at controlling positive symptoms. Remember, positive symptoms we have already mentioned, like hallucination, delusions, disorganized thinking, abnormal behaviors, and all these are what we refer to them as the positive symptoms. For that case, because these drugs, they're blocking the D2, they also can interfere with the nigrostriatal pathway, and this will result into extrapyramidal side effects like the tremors, the stiffness, the involuntary movements. Of course, we have classified them as dystonia, akathisia, tardive dyskinesia, and Parkinsonism. Okay, so these typical antipsychotics can be divided in either high potency or for that case the low potency. Okay, and the difference is simply based on the affinity for the D2 receptors. Okay, you find that high potency drugs are more effective for they are more effective and they have more affinity for the D2 receptors. Okay, so they bind to the D2 receptors more tightly than the low potency. Okay, and the examples include haloperidol, flufenazine, the trifluoperazine, and the prochlorpromazine. Okay, so they after binding to the D2 receptors, these drugs they are more capable of producing the extrapyramidal side effects as compared to the low potency. Okay, low potency for that case. Okay, on the other hand, the low potency medications for that case, examples like chlorpromazine and thioridazine. These guys have low affinity for dopamine receptors. So that means what? You need a higher dose to produce an effect for that case. Okay, as compared to high potency, where even a lower dose will be required to produce an effect for that case. Okay. So the only challenge is that when you look at low potency, for high potency, we say that they only block the D2 receptors, okay? But for the low potency, they are going to block D2 receptors. Then also, in addition, they are going to block the alpha-adrenergic receptors, all right? And also block the muscarinic receptors and the H1 receptors. Remember, when they block these ones, this one is going to result into weight gain and sedation, while muscarinic receptors, this is going to dry the patient. So the guy is going to present with dry mouth, okay, tears, all right, constipation, urine retention for that case. Blocking of the alpha-adrenergic is going to result into orthostatic hypotension, okay? And that's why when you're having this patient, you are supposed to talk to them so that they could do slow changing in position so that they can avoid unnecessary falls and unnecessary injuries for that case, okay? Okay guys, now we can try and look at individual drugs, especially the typical antipsychotics, okay? Number one, we said is the chlorpromazine. Chlorpromazine is a low potency, okay? Is a low potency typical antipsychotic. That means it will block D2 receptors, and in addition, it will block alpha blocking, will also block the muscarinic, and will also block the histaminergic receptors, okay? This drug, if you compare it with other drugs, it has a low risk of having the extrapyramidal side effects as compared to the high potency drugs, okay? Remember, this is the first antipsychotic medication that was developed and is always considered the prototype for typical antipsychotics. You can be able to see it's used for various conditions. You can treat psychotic disorders, including schizophrenia and bipolar disorder. This is sometimes also used to manage some behavioral problems in children, okay? Side effect of these drugs will be associated with the receptors that they are blocking. Like sedation, weight gain, this is associated with the blockage of the H1, while dry mouth, blurred vision will be associated with blocking of the muscarinic receptors, okay? D2 receptors, especially in the nigrostriatal, although it has a lower risk compared to this other high potency, okay? This one will include tardive dyskinesia and the others, all right? Okay, guys. Next, we have haloperidol drug, and haloperidol drug is a potent typical antipsychotic. This is a high potency drug, okay? So it will produce a drug even at a low dose, okay? And it's available in both oral and injectable formulation, including even long-acting injectable for maintenance therapy. This haloperidol is known for its efficacy in controlling positive symptoms, right? But is also associated with high risk of extrapyramidal side effects. So long-term use can also be attributed to another extrapyramidal effects, the one that we refer to it as the tardive dyskinesia for that case. Another drug is the flufenazine, okay? This is another antipsychotic used to treat schizophrenia. It's available in both oral and injectable. Just like other typical antipsychotics, flufenazine will primarily work by blocking the D2 receptors, that is the D2 receptors in the brain, and this normally leads in improvement in positive symptoms, but unfortunately, it will also block the nigrostriatal pathway and therefore result also in extrapyramidal side effects. Common side effects will include sedation, sedation for that case, orthostatic hypotension, anticholinergic effects, dry mouth, and constipation for that case. Next one, we have thioridazine, and this one is historically used to treat schizophrenia, but nowadays it's less commonly prescribed today due to the concerns about cardiac effects, okay? It's associated with long QT syndrome, okay, and potentially fatal arrhythmias. Is associated also with sedation, weight gain, anticholinergic. Remember, this one is a low potency typical antipsychotics. So because of its cardiac risk, it's generally considered as a second line treatment drug for that case. So these drugs These typical antipsychotics could result into several extrapyramidal side effects, and one of it is acute dystonia, right? Acute dystonia is characterized by continuous or sustained spasms and muscle spasms for that case. A good example is the ocular crisis, where you're just trying to eye in the space because of the muscles contraction. In terms of duration, it occurs between the first and the fifth days after drug initiation. Okay. Now, if you want to treat this condition, you could use anticholinergic, okay, anticholinergics like the benzotropine for that case. Next is akathisia. Akathisia is characterized by restlessness, being agitated, of somebody just wants to move about. Okay, so this irresistible desire just to move around. Okay, and this one normally occurs between the 5th and the 60 days just after drug initiation. If you want to treat this one, because these guys are restless, what do you do, guys? You calm them down. And what can you use to calm them down? You can use the beta blockers, beta adrenergic blockers. Example is propranolol. Guys, a link will be popping up on beta blockers. You can be able to see, you can also try and see how they are, those that are contraindicated in asthma for that case, or if someone is having a blockade for in the case. Okay, or someone having asthma drug for that case, or even diabetes. Okay, those ones that these are some of the conditions where this drug may be contraindicated, especially this non-selective drug like the propranolol. All right. Okay, guys, next is Parkinsonism. Remember, we said when we treat schizophrenia, we risk subjecting our patient to another condition, that is Parkinsonism. The patient is characterized by mask-like face with asymmetrical racing tremors, rigidity for that case, and bradykinesia. Okay, and tremors for that case. And this one normally occurs within the first to the fourth week after drug initiation. In terms of treatment, we normally treat using Aten for that case, okay, where we're able to treat these other conditions. All right. Okay, guys. Lastly, we have the tardive dyskinesia that is characterized by protrusion and rolling of the tongue, sucking and smacking movements of the lips, chewing motions, facial dyskinesia, involuntary movements of the body, and even extremities. And this one normally occurs after months to years. Tardive means it takes time. Okay, it takes time to do that. Okay, for this case, this is in this case we can stop the drug. Okay, discontinue the drug in that case. And such a cases is where you find you are going to use clozapine. Okay, clozapine is a typical antipsychotic, right? Okay, you might use that one. Next, we have the last one. We have the neuroleptic malignant syndrome. This is an emergency. This is where a patient is presenting with confusion, muscle rigidity, fever, tachycardia. That in this condition, now this could complicate to rhabdomyolysis for that case, where a patient is having elevated Ks, okay, creatinine kinase, the potassium, and the white WBCs, all right. And all these complications can lead to heart failure, kidney, and even eventual death. Okay, so in terms of treatment, you have to stop that antipsychotic that you are using, the one that has led to those increase in fevers and all of this. After that, you give a dantrolene, okay, muscle relaxant drug, and then you can give dopamine agonists like the bromocriptine, which may be added along with the dantrolene for that case. Okay, guys, so generally side effects of these typical antipsychotics will include extrapyramidal effects, the one that we have looked at, tardive dyskinesia, the same, and all these are related to nigrostriatal area. Blockage in the tuberoinfundibular will also result into the hyperprolactemia for that case. Anticholinergic effects could also result from a blockage of the muscarinic receptors, especially by the low-potency typical antipsychotics, along with alpha, which is going to result in hypotension, and then histamine, which is going to result in sedation, weight gain, and increased appetite for that case. So next we have now atypical antipsychotics. And atypical antipsychotics, these are newer drugs, okay? They block dopamine receptors, but not to a more extent. This will be to a lesser extent compared to the typical antipsychotics, okay? Additionally, these drugs, they also block serotonin. Remember, for typical, we say they mainly concentrate on D2, then maybe the low potency will be looking at alpha, histaminergic, and muscarinic. Okay. Now for the atypical, they are blocking D2 and serotonin. Okay, so this one will be preferred, they are often preferred due to their reduced risk of extrapyramidal side effects, and they have a potentially better efficacy for negative symptoms. Okay, they treat better negative symptoms better because for the typical ones, they are more concerned with the positive. Okay, drugs examples, we have risperidone, olanzapine, quetiapine, clozapine, and aripiprazole. Okay, remember this is the drug that we said we could use when you want to correct the hyperprolactemia. Okay, so negative symptoms, of course, we already know these are things that should be present but will be missing. So the patient will present with difficult expressing emotions, planning, lack of motivation, isolating themselves, and they'll be disinterested with whatever is happening. Examples of these atypical and antipsychotics, we have clozapine, which is often considered as the prototype atypical antipsychotic, and is primarily used in medication where the others have been ineffective due to its effectiveness in treating treatment-resistant schizophrenia. Okay. However, it's associated with the risk of agranulocytosis. Okay, and this is a potentially life-threatening condition involving severe decrease in white BCs. So it requires regular blood monitoring for that case. So clozapine is just kept for only refractory cases. All right. Clozapine is also known in its efficacy in reducing suicide behavior for that case, and that makes it a good drug for those cases. All right. Next is olanzapine, which is widely used to treat schizophrenia and bipolar. It's known for efficacy in controlling both negative and positive symptoms. Olanzapine can be used in combination with fluoxetine, okay, fluoxetine in the treatment of resistant depression, okay, for that case. However, it's associated with weight gain and metabolic disturbances as the sum of the side effects for these drugs, okay. Next, we have the risperidone. Risperidone, this one is efficacious in reducing positive symptoms, okay? And yet it is atypical, all right? It's atypical, but it has been found to have that effect for that case. Quetiapine is the other drug, and this is used to treat schizophrenia. It's known for its sedative properties, and it can be useful in patients with agitation. If the patient is presenting with that, then quetiapine will be the best drug for this case, okay? One who is presenting with agitation for that case. So commonly the side effects of atypical, where we have the metabolic effects, also the extrapyramidal effects is there, prolactin elevation, same as we had said for the others, orthostatic hypotension, especially when you block the alpha-1 adrenergic receptors, right? Anticholinergic effects because of the muscarinic receptors and the QT prolongation on ECG for that case, all right? So in summary, we have now the typical antipsychotics and atypical antipsychotics, okay? Typical antipsychotics primarily block the D2, whereas the atypical are going to be blocking the D2 and the serotonin receptors, especially the 5-HT2A receptors. Typical antipsychotics are more associated with the extrapyramidal side effects like acute dystonia, akathisia, tardive dyskinesia, while the atypical ones still may cause metabolic waste, side effects like weight gain, diabetes, and lipidemia. Okay, although these are likeless of resulting in this extrapyramidal side effect. Okay. In terms of efficacy, typical is very efficacious in treating positive symptoms as compared to the atypical, where positive and negative can be treated, more so the negative symptoms. So typical antipsychotics mainly affect dopamine transmission. This one we have already stated they're affecting the dopamine along with serotonin. So typical antipsychotics have been traditionally been used as the first line medication, but this one are now considered first line due to the lower risk of having the extrapyramidal side effects and also potential for treating the negative symptoms, which the typical are not able. Okay, so there's a high affinity for D2 receptors, and we have given examples like promazine, haloperidol, and on the other hand, we've said the affinity, there's a variable affinity for the D2, and they've given examples like the clozapine, risperidone, and ariprazolol. Okay, so guys, thank you so much for having me today. We have been looking at antipsychotics, which are also referred to as neuroleptic agents. Guys, you can get into the description section just to find the quiz so that you can test your knowledge on the case on this presentation to find out how far you are. In addition, you could also just see how to conduct a mental status examination in the other lecture. Thank you so much, guys, and see you in class.